the potential advantages of cannabis is that it's really possibly a new therapeutic drug class, because it acts on cannabinoid agonists and also on cannabinoid endogenous systems. And so the mechanism of action are very different from those of other drug treatments for neuropathic pain. So that's one of the major advantages of cannabis compared to other more established pharmacological drugs. Actually, yes, that's an important question, because our controversy during the EAN was exactly on this. Actually, if you look at the evidence, it's very, very different depending on the type of pain you consider. If you take spasticity, for example, or spasm-related pain, then the evidence is good. And for this reason, for instance, nabiximol is authorized for use in several countries for spasticity and pain. But if you look more carefully on neuropathic pain, which is one of the major indications for cannabinoids today, the evidence is not so good, because we have many, many trials which have been of good quality, which have investigated the efficacy and safety of cannabinoids in neuropathic pain over the past decade. And now we have approximately, I think, 11, which is not a little number, and it's a large amount of patients with peripheral or central neuropathic pain, so various etiologies. Some of them, and there was essentially two cannabinoids that were used in these trials. One is THC, which is tetrahydrocannabinol, which is Marinol, and the other is nabiximols, which is Sativex, which is the most important number of studies concern Sativex. And if you look carefully at the evidence, well, there are more negative than positive studies on the primary outcome. Doesn't mean that it doesn't work, but the evidence is this one thus far. Of course, there are potential safety issues of using cannabinoids on the long term, but in the trials in neuropathic pain or spasticity, there were relatively little safety issues and very little risk of abuse or misuse. It doesn't mean that it doesn't exist, but it's relatively rare. But in all cases, when we propose to use these drugs, they should be, of course, envisaged only in patients with no risk of psychoactive use of cannabinoids, or with problems of misuse of other drugs, for instance. So that's one concern. Regarding the other side effects, they are essentially central side effects, and of course, these are the problems of somnolence, vigilance, in some cases, and very, very little cases of psychiatric decompensation. That's very, very rare, and it concerns only patients who have a psychiatric background. It's very rare. So the risk is not that bad. The problem is rather the fact that, unfortunately, the evidence for efficacy is not as good as we could imagine. In the clinical trials, patients were generally evaluated very, very globally. Their pain intensity was the primary outcome in general. And as I said, it didn't always turn positively. Sometimes it was positive, but sometimes also there was placebo effect, and so it was not negative. In our experience, and also maybe in clinical trials, it might be that there are at least two symptoms or two types of patients that might benefit. One is the patients with allodynia. At least there are some positive studies of one published in patients with peripheral neuropathic pain some years ago, in patients with evoked pain, and this study was positive in these patients. And the other possibility is that cannabinoids also act mainly on pain paroxysm, which is, it's not like spasticity, but there are similarities. It's more electric shocks, stabbing pain, so the type of pain which can be terrible in these patients. It is not completely established, but it seems that these patients are also more likely to benefit from these drugs. I am absolutely not against the use of cannabinoids for neuropathic pain, and conversely, I would really like to use them, because I do think that they represent a new avenue, a new potential therapeutic. I'm very sorry that the studies are not all favorable to the use of this drug. I do believe that they are really interesting. However, I think we need maybe other evidence, also maybe large-scale observational studies. We need that too. In France in particular, what we're going to do in a few months is that we're going to use them, cannabinoids, in real life with the French Agency on Medicinal Use. With the aim of this agency, we're going to be able to prescribe cannabinoids to a large number of patients with chronic neuropathic pain, with several types of cannabinoids, several concentrations, and we will have probably a better idea of the real life efficacy and safety of these drugs. We don't have any data in France in particular, and we have not so many data in many countries actually. So we need more evidence from good studies, but we also need more global and huge evidence with large number of patients.